Hi, I'm Shandra Wilson. I'm a urologist in Colorado, and I do a lot of bladder cancer. So one of my patients said you should update your vids. So that's what I'm going to do. This is a little bit more informal than the old videos I had that I did at the university. But at least it can kind of give you information before you come to see me in clinic. So I have a few things to tell you about. I'm going to go a little bit about me, a lot about you, the treatments for bladder cancer, outcomes to expect from those treatments, what the side effects of treatments could be, where to have surgery or how to pick that sort of place, and a few questions about surgery. The first thing about me, I'm a Denver native. I grew up in Colorado, went to school at WashU in St. Louis, and then USC for residency, and then came back to the University of Colorado for a fellowship. That was a year where I studied cancer on top of having done urology. So I'm a cancer fellowship trained surgeon, and bladder cancer is my subspecialty. I was at the university for 15 years. I started as assistant professor, then got to associate professor, and made it to full professor in 2018. And then decided to get my MBA and mix it up a little bit, and now I work at Littleton Hospital, where I can do MBA stuff as the chief of surgery, kind of be part of quality and safety at the hospital, but also do surgery. Things about you that I might expect. More patients are older that have bladder cancer. It used to be that a lot of patients smoked, but in our Rocky Mountain region, only about 11% of patients smoke. So it's actually pretty rare that patients with bladder cancer smoke. It is something that's thought to be sporadic, so something that without any risk factors can happen. So the older one gets, the more the cells divide and the more likely cancer can happen. So most of my patients are over 50, although I have had to take out a bladder of a 16-year-old that was from Saudi Arabia. And then they say after lung cancer, bladder cancer is the second most mediated by the environment. So we're not totally sure, but there may be a history of exposure to paints or being in the military or fumes from solvents and chlorine in pools that have been unventilated and that sort of stuff. Some patients have also had a history of radiation. Radiation is good because it cures things like prostate cancer, but it may increase the risk of bladder cancer. As far as bladder cancer goes, the most important thing is how deep it goes into the bladder. So I'm going to get my computer here for just 1 second. And this is a good schematic of bladder cancer. And some patients have tumors that are just like little mushrooms on the surface of the bladder. This is stage A. It can be a little bit deeper where it starts to be stage 1 and close to the muscle. Those patients usually get BCG to try to prevent it from going into the muscle. And then if it gets into the true muscle of the bladder, or stage T2, it's considered invasive bladder cancer. Interestingly, most of the patients with invasive bladder cancer are genetically different than those that are superficial. So it's not like one grows into the other most commonly. If it's stage 2 or greater, where it's stage 3, it goes into the fat, or stage 4, it starts going into other organs. Then we start talking about a more aggressive treatment than just scraping out the bladder. So what would these treatments be? We usually now rely on the NCCN. So it's National Cancer Comprehensive Network, and this is a group of organizations that doesn't have any financial relationship with any pharmaceutical company. It doesn't have a particular affiliation with any specific hospital or physician, and they review the literature every single year and make sure that all of us as a group are doing what's best for patients with cancer. And patients can go to nccn.org, and this is now where we get our treatment guidelines. So it's been found that if we follow the guidelines, outcomes are 15 to 20% better. So that's what we do, that's what's recommended. So if we looked at the NCCN guidelines, the first level treatment is chemotherapy, so that's usually about 3 months of IV medication that helps shrink everything down after the diagnosis of invasive bladder cancer, followed by getting the bladder out. So this usually works about 85% of the time. So at 2 years, 5 years, 10 years, and 20 years, most recurrences are in the first 2 years. Survival with this combination is about 85% success. If you're a type of patient that just might be prone to bleeding or just can't have surgery, radiation is a good backup option. It works 50 to 60% of the time. Again, chemo should be done before the radiation to sensitize it and make it work better. And then if neither of these sound good, if a patient is 85 or 90, things like observation can be tried. But the average survival for observation is about 1 to 2 years. So it might feel like, gosh, these are big options, this is a lot of treatment, and it really is. But it is a pretty aggressive cancer compared to skin cancer, where almost nobody dies, it doesn't spread, or pancreatic cancer, where it certainly can spread and take your life even with treatment. Invasive bladder cancer is more towards the pancreatic side. Clinical trials can also be used for bladder cancer, and at this point in time, they're usually equivalent to our current standard or a little bit better. So a lot of patients get involved in these, and in general, it's encouraged because it usually helps the patient as well as other patients with bladder cancer. Now I'm going to grab my computer one more time. This is a big question that comes up, and bcan.org is a great reference. So this is for, this was started by a woman whose husband had bladder cancer. And she started this organization as a support group for patients with bladder cancer. And if you have bladder cancer, you can log on, and it's a secure chat room where you can get information from other patients who've had this disease. And they can help share information about a conduit, which is a bag on the outside where we connect the ureters to a piece of intestine that goes to the skin, and then there's a bag on the outside. Or an Indiana pouch that not too many patients choose, but we can build a pouch on the inside and it goes to the belly button. So a patient would catheterize their belly button to empty the urine, or the neobladder, which about 85% of patients use. We take a piece of intestine, we fold it into a bladder, hook it to the ureters and the urethra, and it functions essentially like a normal bladder. All of these options are equally good, and it kind of just depends on what your lifestyle is like, how old you are, what sort of facility you live in, if you live in a nursing home or if you're at home. All of them work, and we just try to fit the right one to the right patient. This surgery can be done robotically as well. It does add a little bit of time because the robot has to come in and get docked. There is still an incision to take the bladder out and do a little bit of the reconstruction, but robotics does decrease the amount of blood loss and maybe how long patients stay in the hospital. The average hospital stay is about 5 to 7 days when a patient has invasive bladder cancer and gets their bladder taken out. The main side effects of surgery, there are several because it's a big surgery. It's taking out the bladder. If you're a male, it's also the prostate, then the lymph nodes, and then taking out a piece of intestine. So it's basically 4 surgeries in one, so it takes a while to recover. I tell most patients it's about 3 months before they'll be happy they did this, but there is really nothing that works better in the long run. Side effects that can occur include what we call ileus. That means the intestine just stops working. This happens in 60 to 80% of patients. Ways to avoid ileus are to decrease narcotics. So our patients, we usually give them an epidural so they don't need as much oxycodone or morphine, because that's been known to cause constipation and slow the bowels down and cause this ileus or slow bowel function. Other things that prevent ileus are walking. So that's the part that the patient can do. The more walking, the less the bowel kind of backs up. In addition to that, gum chewing can kind of help move the intestine, and if we choose pain medication that's non-narcotic, it can also help avoid constipation. Other things that can happen include a need for repeat surgery. This is less than 1%, but there is a chance that something is too tight or that something opens up and needs to have surgery again. There is a chance that one of the needle holes that we use to build the diversion opens up a little bit. This usually heals with time, so that is not a surgical emergency. Dehydration, we do see this in about 10% of patients. So we tell all patients that go home to try that fluid is their best friend. Usually fluid goes through easier than solid food, so small meals frequently and drinks with calories are the best way to prevent dehydration. Infection can happen. It's our most common reason that patients come back in the hospital. So patients do go home with antibiotics until all of their hardware is out. And the last thing we worry about is blood clots. So patients will be hooked up to machines that circulate their blood and are kind of leg squeezers while they're in the hospital, and are also encouraged to walk to help avoid blood clots. As far as where to get surgery, BCAN is helpful, the NCCN is helpful. I did this for about 15 years at the university, and one of my students helped patients get a book together called You're in Good Hands that you can buy on Amazon. And it's just 50 patients who have been through this surgery, and it's very realistic as to what it's like, slowly getting better and getting to the other side of this. I also have a website, wilsoncancersurgeon.org, that answers some of these questions. Other questions that we frequently get: where to have the surgery. I have found it's better to get it in a place where you have some support at home. If you live alone, it may be helpful to get involved in a rehab center after surgery. It is just a very major surgery. It's good to try to, if you're coming in from out of town, try to stay in town for the 2 to 3 weeks while it takes for everything to recover, if possible, just in case you need to make appointments for antibiotic changes or catheter changes while you're getting through the acute recovery period. It is helpful to get these done in a place that does a lot of them, because it's a complicated surgery and can have complications. The last thing when choosing a place to have surgery is a place that has availability and the availability to answer questions as patients go through. And I think that's it for now. I'm so glad to join you, and hope I answered some of your questions about invasive bladder cancer.